Good morning or afternoon, everyone. Thank you for joining us for this webinar. We're presenting on behalf of the NRG Oncology Study Team, NRG-GU015, the randomized phase 3 trial of adaptive radiation and chemotherapy for muscle-invasive bladder cancer, also called the ARCHER trial. There is an approved pending amendment that hopefully everyone will be hearing about soon. Next slide, please. So we have a very large study team here. Of course, this would not have been possible with the late, great Felix Fang. So we have a few of the study team members here today that will be presenting on this webinar, really highlighting the amendments and some radiation planning changes that are happening shortly. Next slide, please. So this is just a list of everyone. We're all available for contact. So the background and rationale is bladder preservation and chemotherapy with chemotherapy and radiation is a standard of care option for muscle-invasive bladder cancer. There's emerging evidence to support stereotactic body radiotherapy or ulcer hypofractionation, SBRT, for muscle-invasive bladder cancer. And we now know there's multiple technological advances in radiation planning and treatment delivery with both plan of the day or adaptive technologies that are available and can improve target delineation coverage along with minimizing potential toxicity. The level 1 evidence for this is supported for chemo-RT, both in the NCCN, where the bladder intact event-free survival is approximately 50% at 3 years. This was an assumption based upon the SWOG 1806 NRG trial. An individual patient meta-analysis of 2 randomized trials, both BC 2001 and BCON, demonstrated lower risk invasive local regional recurrence and similar toxicity profiles of hypofractionated radiotherapy given in 55 gray over 20 fractions compared to conventional fractionation of 64 gray and 32 fractions. The hypothesis behind this is that potentially a lower alpha beta value of bladder cancer and shortened time factor is what led to this improved control, which is why 55 and 20 is the standard arm on this. As you can see on the right through the Lancet publications, that this analysis really did favor shortened treatment time over 4 weeks compared to a more traditional 6 to 7 weeks. So now there's emerging data to support ultra hypofractionation in muscle invasive bladder cancer. This was the hybrid trial, which was a phase 2 randomized control trial at 14 hospitals in the UK. Their dosing regimen was 36 gray in 6 weekly fractions. It was randomized to standard or adaptive planning. The local control rate was around 82% at 3 months. Again, remember, this was no sensitizing chemotherapy or any systemic therapy for these patients, with acceptable non-GU toxicities with the adaptive planning arm, along with non-GU and non-GU toxicities in the adaptive. Turn it over to you, Scott.
Yeah, so, I mean, this trial was born out of really the success of the SWOG NRG 1806 trial. So at that time, Felix and Jason approached Himanshu and I to really get started on designing the next trial. And a couple of questions were asked. What's the clinical question that we want to ask? Can we answer multiple questions? And really, from a patient-centric standpoint, what was the biggest barrier we had for a very successful trial like 1806, which we're still pending the data on? What was the biggest barrier to TMT? We were obviously a high site enroller for 1806, and one of the biggest barriers was just getting patients to the radiation center, because that was 6.5, 7 weeks of radiation therapy. They did not allow conventional hypofrac on that trial. And there are a lot of opportunities. I'm from the southern part of the United States, and there are a lot of patients that get no curative intent treatment with muscle-invasive bladder cancer. And it's estimated that 1 in 4 patients with muscle-invasive bladder cancer receive observation alone. And when you talk to a lot of these patients, because I see them, they refuse cystectomy, but they cannot travel from their rural location over the course of 7 weeks. So something that was more pragmatic would definitely allow us to apply a curative intent treatment to a population of patients that are otherwise not receiving any treatment. So The biggest barrier to TMT, outside of just consensus within our GU multidisciplinary teams, but I think that's changing. I think the biggest barrier from the patient standpoint is the travel. What's the clinical question? Well, we decided to ask a very simple clinical question. Is 5-fraction SBRT non-inferior to conventional hypofrac, 55 and 20? That's the simple question. But can we incorporate multiple other questions, even if it's just observational within our trial? Can it actually even be more pragmatic than what I think was already a very pragmatic SWOG NRG trial with the PI Parminder Singh? Can we even be more pragmatic than 1806? And I think we've accomplished that. The key inclusion criteria for the Archer study are patients who are T2 to T3B, urothelial carcinoma of the bladder. They have to be node negative, no evidence of metastasis. We exclude patients with T4. They must undergo a TURBT prior to randomization. So unlike over in Europe where they'll just do chemoradiation, we do require TURBT. Patients don't have to be completely resected, but they have to undergo a radical resection in an attempt to completely eradicate the tumor. They must undergo radiographic cross-sectional imaging prior to randomization. That time frame is within 90 days. So CT scans, MRI have to be redone within 90 days, especially if the patient's getting neoadjuvant chemo. And you can't have diffuse CIS based on cystoscopy and biopsy. Don't ask me to define diffuse CIS because it's undefinable, but everyone knows what it is when they see it. This is the registration. So this is the schema. You confirm eligibility. Patients can then be stratified. These patients that come onto this trial could have received neoadjuvant therapy. They're not required to have received neoadjuvant therapy, but they could have. Many of our patients are getting EV Pembro. They're getting 3-4 cycles. Then they're coming onto trial. That is up to the discretion, and that happens before this trial. Patients could have gotten Gemcitabine or Valimab. Stratified based on, yes, you received neoadjuvant therapy or you did not, whether or not you're T2 versus T3, and then what is your planned radiosensitizing chemotherapy regimen? CIS, GEM, which can be given weekly or twice weekly, or mitomycin C5FU. And then patients are randomized. Both arms are exactly the same in every way except for the radiation. Arm 2, our experimental arm, the arm that the hypothesis is that it's non-inferior. That arm gets SBRT with 5 fractions delivered over 4 weeks. Arm 1 is conventional hypofractionation. Both arms get the same schedule of radiosensitizing chemotherapy. Neoadjuvant therapy is allowed but not required on this trial. So this is a little bit different than the SWOG trial, which requires it. We do not require it, but you can give it. That's up to the discretion of the sites. Primary objective, demonstrate non-inferiority of SBRT compared to hypofrac RT with a 10% non-inferiority margin, and BIEFS at 3 years. Secondary objective, looking at toxicity rates, urinary and bowel, patient-recorded outcomes, event-free survival, metastasis-free survival, and overall survival between the 2 arms. Compare and evaluate symptomatic adverse events and quality of life measures for the patients. And then integrated into this trial is a prospectively defined ctDNA endpoint where we're going to evaluate ctDNA as a biomarker to determine whether or not it is predictive of disease recurrence as a secondary outcome variable. ctDNA is provided on the study once you come in on the study and you're randomized. And that data is given back to the sites, which can then be given to the patients. It is real time, just like if you were ordering it commercially. Exploratory objectives is to evaluate other ctDNA, tissue-free MRD, and urine tumor DNA throughout the trial, as well as the time of progression. When I said our goal was to try to be more pragmatic than a very pragmatic SWOG 1806. I think we've accomplished that. We have an amendment that's coming out as well. That amendment should hit within the next 2 weeks. So some of what I'm talking to you about today is not active if a patient goes on trial today, but it will be in 2 weeks. Currently, we have very wide windows. It's 180 days. We heard from sites that some patients were getting neoadjuvant therapy, and that 180-day window was a little bit difficult for them. So in patients that received neoadjuvant therapy, if they got 4 cycles of EV Pembro, any patient who got neoadjuvant systemic therapy prior to consolidation, that time frame has been moved from 180 days to 240 days to give the sites a little bit more breathing room. Remember, there are no pelvic nodal fields here. This is all clinically node negative. Clinically node positive are excluded. We have removed the mandatory post-radiation treatment biopsy at this point in time. Going forward, as soon as that amendment is active within the next likely 2 weeks, all that is required is cystoscopy and cross-sectional imaging, as would be standard of care. No biopsy is required. No repeat resection is required in patients who received neoadjuvant therapy. So if a patient comes in January, gets neoadjuvant therapy, January, February, March, wants to go on trial in April, they can go on trial in April without a repeat TURBT. Now, they are required to have cross-sectional imaging, but they're not required to have a repeat TURBT. That's been active since day one. Imaging windows are within 90 days of enrollment. That's most pertinent for your patients who are receiving neoadjuvant therapy. We will be requesting with the new update for our sites to upload prior commercial ctDNA testing for the patients. Real-time feedback results will come to patients and the providers and the study teams for the longitudinal ctDNA, and this aligns with standard of care visits. So when the patient's in the office, they're getting their ctDNA at the same time. Remember, stratification is neoadjuvant therapy, yes or no, T2 versus T3, and then what radiosensitizing chemotherapy you're given, or are you giving or planning to give. Adaption is also pragmatic. So we couldn't design a trial just for people who have an ethos, an EVO, or an MR-Linac, a Unity. There is a plan of the day option, so that way this can be extrapolated out to community conventional CT-based linear accelerators. We're also very silent on post-surveillance standard of care. So after treatment is done, we are prescriptive in terms of the follow-up, which is just per NCCN guidelines, but we are not prescriptive to sites on what they do adjuvantly, what they do when ctDNA comes up. That is left up to the sites, and that is not part of our trial. Target accrual is 486 patients. The study activated in August of 2025. As of this morning, 22 sites have enrolled at least one patient. May last month, we had greater than 10 enrollments, and so I think we're almost at 50. We're at 49 as of 10 o'clock this morning when I pulled this data. I'm going to turn it over to our treatment planning team.
Hi everyone, my name is Rojana. I'm one of the 2 physics chairs for this study. So Kate and I today will be talking a little bit about treatment planning, margins, and some of the questions that come up during the credentialing process. Next, please. I will point out a few things that are coming up in the amendment. A lot of this was basically based on questions that came up. So one thing that is sort of relevant, there are no changes in the, obviously, dose or fractionation. But one question that comes up very frequently is the scheduling. So for arm 2 patients, the delivery schedule is supposed to be within 20 days, 20 business days. So what that means is that it should be 1 fraction for 3 weeks and 2 fractions in 1 week. It doesn't matter what order, but it cannot be 2 fractions and be done in basically 2 weeks. So it needs to be spread out 1 fraction per week, and 1 week can have 2. So this comes up very frequently, even at our own site, when it gets scheduled. Next, please. So some of the planning questions have led us to sort of try to explain a little bit better in the upcoming amendment how to define targets or PTVs basically, and what to do if you're choosing to have one planning CT versus multiple planning CTs if you're doing plan of the day. So for plan of the day, regardless of what arm the patient is on, the general recommendation is that you do one CT scan or MR if you're MR-based planning, and that image is basically with an empty bladder. In the original amendment, for that small bladder PTV, we were asking for a 5 millimeter isotropic expansion from CTV to PTV. And from everything that we have seen so far, this is a slightly tight margin for that. So it is changing to 0.7 after the amendment is active. So for now, it still stays at 0.5, but once that amendment is approved, we are changing that to 0.7. You can see the description of the medium and large there. There is no changes in that one. It stays the same. And one thing that was very vaguely described in the original amendment that we're going to expand on a little bit in this new version of the protocol is that if you're using 3 different planning volumes initially, meaning you're doing 3 CTs or 3 MRs with different bladder filling, then you would not want to create these very large margins off of those fuller bladders, basically. So if you're doing 3 different volumes, then each of those volumes, that CTV small, CTV medium, and CTV large, should only be expanded by 7 millimeters uniform to create the small, medium, and large plans. So that is something that, again, that is not a change, but it's really more of a clarification that is coming up based on the questions that we are getting. Next. For online adaptive for both arms, again, the same thing, no change in the actual CTV to PTV expansion. But if you are going to use patient-specific margins, you want to be careful with how you're doing your different timing of your initial CT or MR scans up front, and sort of have a sense of what is going to happen when the patient's on the table and you're doing online adaptive, how much time it will take you, how much their bladder will fill. So it is optional if you want to do a patient-specific margin, but it needs to be at least 7 millimeters regardless. Next. We also did a little bit of clarification. So for plan of the day, there is an isodose line of 33 grays for arm 2 patients that we are trying to make sure that the bowel stays outside of this for planning and then for online setup. And so if you're doing plan of the day, we just clarified that you basically need a different 33 gray isodose line for your small, medium, and large plans. There was a slight change in how the bowel is defined, or it was basically clarified that you need at least 2 centimeters superior to the PTV bladder. If you go to the next slide, I can talk about the planning priorities. So this is probably one of the most common questions that comes up when people are going through credentialing. So the goal of the plan of the day is that if you're planning based on a single scan with an empty bladder, basically, or bladder small, for that small plan, you're going to meet all of the bowel objectives. If you're now going to potentially use the medium or large at the time of treatment because the bladder is a little bit fuller when you do your initial imaging, if you are planning off of that one single scan, you're going to be significantly underdosing that area. So at the initial planning, you're basically going to have to ignore the bowel constraints, knowing that when that bladder fills up, the bowel will be moved out of that space. So for the arm 2 patients, basically for medium and large plans, you have to ignore the volumetric 33 gray bowel constraint. For medium and large, you still need it for the small. And for arm 1 patients, it's 2 different dose levels that are higher than your prescription. Again, you're ignoring those in the medium and large plans and meeting everything in the small bladder plan. And then the one other recommendation, and we have, again, all of this in the amendment that's coming up, is that you generally want to keep the CTV, any hotspots inside of your CTV as opposed to it being at the edges, because there is potential for that bowel to be in that space at the time of treatment. Next. All right, Kate.
All right. Hi, I'm Kate. I'm the other physics co-chair on the Archer trial. Next slide. This section, we're going to talk about the pre-treatment and credentialing process, specifically what DICOM files need to be submitted in Triad, and then what the overall credentialing process. So there's a pre-treatment review that's required for the first arm 1 and arm 2 patient enrolled for each institution prior to treatment delivery. Arm 2, we changed this in this amendment coming up in a couple weeks. If a site chooses to use both plan of the day and online adaptive, then both these first two patients need to go under credentialing for the pre-treatment review and the adaptive review. A second pre-treatment review, which is what we're calling the adaptive review, is required for the first arm 2, the SBRT arm patient, for each institution after the first fraction and prior to fraction 2. This is required for, as I said, plan of the day and both online adaptive. If that second pre-treatment review or online adaptive review is not approved, then the patient will have to undergo a third pre-treatment review for the second fraction, et cetera. This is the timeline for the pre-treatment review. As we talked about, that first pre-treatment review is done at the end of planning. We have 3 days from the time that the DICOM files are sent to Triad for us to send back the review. And then once it's approved, first fraction will happen. And then for the SBRT arm, that will undergo a second pre-treatment review. Next slide. In terms of the DICOM files submitted, so for our arm 1 cases, this is the standard hypofrac arm. This is non-adaptive, and all of the DICOM initial planning objects are required for submission. So that's your CT, your planning MR if that is used, your RT structure set, and your RT dose and your RT plan. So that's straightforward. So for our adaptive, next slide, our online adaptive or plan of the day. So first will be that pre-treatment review that's done on the initial plan. We will require the following DICOM objects. We're going to need, if you decide to do the 3 sets of CT images or MR images with the differential bladder filling that Rojana was talking about, then you'll go ahead and submit all 3 of those CTs or MRIs. Then if you have the 3 CTs or MRIs, then we'll need 3 structure sets for each of those. For those of you who just do 1 image and then do the expansions based on the trial for small, medium, and large, then just 1 CT or MRI will be submitted and 1 RT structure set will be submitted. Then we'll also need 3 DICOM plans, no matter what route you take, for both RT plan files and then RT dose for small, medium, and large. For our adaptive plan of the day approach, so after fraction 1 has been delivered, you will then submit your planning MR or planning CT on the planning CT that you used to treat that day, the RT structure set, the RT plan for the plan you treated that day, and the RT dose. Then we've gotten a lot of questions in terms of the post-imaging, what cone beams are needed to be submitted. So we need 2 images for plan of the day. We need the post-adaptive, which it's plan of the day, but it's the pre-treatment image. So it's the image that you use to select which plan to deliver, and the post-treatment cone beam, which is helpful to know how much bladder is filling and if we need to make adjustments for the patient. So MPO, et cetera. Next slide. For online adaptive, it's similar for the pre-treatment review. And then for the post-treatment review, we're going to be submitting just the planning image of the day, the DICOM RT structure set, the DICOM RT plan file, and the RT dose. For online adaptive, we actually need 3 images. So the plan of the image of the day, the post-adaptive and pre-treatment delivery, and then the post-delivery image. So let me just repeat that one more time. So it's the initial image that you acquire that you're going to be performing your online adaptive on. then your post-adaptation pre-treatment delivery verification image, and then lastly, it's your post-treatment delivery image. For all of our cone beam CTs or MRIs for the MR-Linac systems, we actually need your SRO file in order to see the image registration for that with respect to the primary scan. Next slide. All right, and that finalizes our presentation, and we're ready to open up for Q&A.
Any questions? Let me see where the chat is.
I don't see any questions yet, but we can give it a minute or so if people are typing.
All right, let me stop sharing my screen. It's always good on a webinar when you have no questions. Either no one attended or you did a perfect job.
Since this is about RT, since we have the med physics here, do we want to discuss what are the biggest hurdles we've seen currently with the current protocol and any like responses that you guys had, just since a lot of these are I know we had a lot of some issues with the RT and with the amendment that is forthcoming with the current protocol now, if you guys want to discuss like how you resolve them, that might give people more questions.
Sure, I'll start. I think the main thing that has been a problem for the credentialing cases is sort of getting comfortable with submitting a plan for medium and large plans where you're not meeting the bowel constraints. So it's not something we ever do clinically, so it's very difficult for people to get comfortable with that, but it's really needed because otherwise you're significantly underdosing the bladder. So that's been a common thing. I think that will hopefully, with that description in the amendment, it will get resolved. That is, I think, on the planning side has been the main thing. Kate, do you want to bring up any of the submission issues with SROs?
Yeah, so definitely that's unique to our trial is that we need the SRO, and that we've been having challenges getting that over. So if the SROs do not come over, we're happy to work with the site, get on a Zoom with them, to see what their record and verify system is and try to help them walk through getting the SRO file out. I would say related to SROs is the other kind of unique challenge that we've seen in registration for the plan of the day technique has been really important for our trial is to keep the bowel outside the 33-gray isodose line. So instead of perfecting maybe the PTV alignment to the bladder itself, is actually it's more important to, yes, get the bladder within the PTV for that either small, medium, and large PTV, but also keep in mind that bowel loop that's proximal to your 33-gray isodose line. So we've told institutions to kind of just try to shift the bladder to be within the PTV, but keep the bowel outside the 33-gray isodose line. I guess in the last thing that we've seen that's been challenging has been the bladder filling. So as we said, NPO is maybe having the patient NPO for a little bit longer, not eating or drinking prior to a little bit longer. The other unique thing we've had some sites do is actually have the patient void prior and start with a small, or maybe even void between the two VMAT arcs, and then cone beam from there.
I think to that point, a lot of these patients are getting chemo on the same day and they're getting IV hydration. So it's tough to necessarily keep, even they're the NPO. So really strict sort of urinary protocols might be helpful. And as Kate mentioned, sometimes between the arcs, they may just have to go to the restroom again to avoid to keep that small bladder. So that's one practicality that we've seen both on the trial and even patients that I've treated.
We try to do our patients from the radiation standpoint first, and then send them to infusion because obviously if they're getting cisplatin, they're getting hydrated pretty darn well. Someone else commented on the video. Yeah, if you go to the nrgoncology.com//Archer, there is an IRB approved patient facing video that describes the trial, the rationale. That's, like I said, it's IRB approved, and we have found that very useful in our clinics to explain the trial.
One other question has come up for patients that are really set to enroll on trial, but still need to get their neoadjuvant therapy potentially. That does need to be completed first. So once they register, there's a 28-day window. So I know Scott, myself, others on the trial do this. They complete it, see them in follow-up, get their scans, and then enroll them on trial.
All right. Anything else in the chat?
Just to let all attendees know, there was an issue with the chat, but everyone can message on it now if they would like to. Andrew just got an email. Okay. We can give it a minute. And just to remind everyone, the video of this webinar is going to be posted to CTSU. It'll probably be a few days, so next week, it'll be posted. And as a reminder, the amendment has been approved, but it hasn't been broadcasted yet. We'll probably notify everyone during one of the weekly Monday broadcasts when it's ready, so just please look out for it. But we anticipate the amendment to be broadcasted hopefully very soon. Okay, and I don't see any chat or questions, which means this is great. You guys have covered everything. Do we have any final comments before we end this webinar?
I just want to thank all the sites for opening and enrolling. The entire team is here for you. Our cell phones are available, our emails. So please reach out if you have any questions on any portion of the trial. And again, thank you for everyone for opening and enrolling on this trial. It's a very patient, pragmatic, friendly trial.
Second that. Thanks, everybody.
You're welcome.
Great. Thank you
Bye-bye.
so much, everyone. Have a great day.